The program for today, osteoporosis. One of the first questions is, we assume it's just women. The reality is it's not just women, it's men too. And we'll talk about that for just a minute. And then we're going to talk about bisphosphonates. We covered osteoporosis a few weeks ago, but we covered mostly lifestyle issues and supplements. Things where you're doing weight bearing, and even weight bearing that may cause problems for things like joints, things like jogging, walking with a vest, weight vest on. Those are all things that are major lifestyle improvements for osteoporosis. You want to do that when you're young, when you have your hormones going. You want to tell your kids to do that, your grandkids, because that's when they can respond to the extra stressor on the trabeculi of their bone. What's trabeculi? We'll talk about that in just a second. Right here. Here are two sections of the bone. The first is the cortex, or the outer lining, and which you see is solid. And then the inside is a trabeculi. It's like a matrix. This is a healthy bone. This is what an osteoporotic bone looks like. As you see, you get some decrease in the cortex as well as especially noticeable in the trabeculi of the bone. Osteoporosis, as most of us know, it's characterized by reduced bone mass, increased skeletal fragility. Boomers, those of us who were born between 46 and 64, 300,000 per year are hospitalized for hip fractures. Now, this is a serious thing. 20 to 30% of us that are hospitalized for hip fractures are dead within the year. That's how serious it is. We're talking like a 20 to 30% mortality rate in 12 months. I mean, that's as bad as some of the really bad cancers like lung cancer. It's not quite as bad as heart attack. 50% of us die immediately after heart attack. But it's still very, very serious. Between 2000 and 2015, there were fewer fractures and there was a 15-year decline in the fracture rate. So it was a huge progress for us on a public health perspective. We'll talk about that in just a minute, why that happened. But before we do, 80% of hip fractures due to osteoporosis are never treated, and many of them are never even noticed. So let's talk for a second about men and women. Is it just women? No, it's both men and women, and obviously one of those things you got to deal with aging. As we all know, getting old is not for sissies. 25 million people in the U.S. have osteoporosis, over 2 million fractures per year in the U.S., women much greater than men. 4 times higher osteoporosis rates in women and 2 times higher osteopenia. Now, wait a minute. I used 2 clinical terms there, and what's the difference? They're the same process. Osteopenia is just a little bit less bone mass. Osteoporosis is a lot less bone mass. That's the difference. So as you see, women are twice as likely to have moderate amounts of bone loss, 4 times more likely to have very significant bone loss. Women have fractures 5 to 10 years earlier. 1 in 5 men over 50 will break a bone due to osteoporosis. That's 20%. That's a lot of us men. Now, hip fractures are a major public health concern because of the high mortality. Morbidity is a big issue. What's morbidity? It's basically a big impact of a disease on somebody's life. This is a disabling issue. It's very much like heart attack or stroke, maybe more like stroke, in that you usually have a significant disability if you have a hip fracture. And with all of these things, healthcare expenses are through the roof. In recent years, there's been less bone density testing and fewer prescriptions for osteoporosis treatments. Rising concern of possible adverse effects on hip fracture rates. There's been a lot of issues. Medicare reimbursement has declined for treatment for osteopenia, and it's been due to fear of bisphosphonates. You see this headline from the New York Times. This is a perfect storm for broken bones. People are just getting afraid of bisphosphonates. They're not taking them. And look what happened. There was a steady decline in hip fracture rates. More than 3 or 4 years ago, about 3 or 4 years before the end of this study, the concern about bisphosphonates started to hit the airwaves, started to get publicity. People stopped initiating bisphosphonate treatment. They'd get the recommendation from their doc, and then they say, I've heard bad things about this. I'm not sure I want to take it, and they wouldn't start it. So starting back in 2012 and up to 2015, and we don't have good data yet starting from 2015, but it appears it's continuing. We're not managing hip fractures like we used to. Had the decline continued the way it was going, there would have been 11,464 fewer fractures between 2012 and 2015 at the time of that study. This was a study done in Osteoporosis International magazine. It was an analysis of U.S. Medicare claim data for women 65 and older from 2002 to 2015. It was age-adjusted hip fracture rates. They calculated it, they weighted it to the 2014 population. Hip fracture rates declined each year from 2002 to 2012 and then remained stable at levels higher than that projected for years 13, 14, and 15, as you can see from the numbers. What's the fear of bisphosphonates? What's going on with those? Osteoporosis-related bone loss occurs when bone resorption, in other words, pulling the calcium back out of bone, when that exceeds bone formation. Bisphosphonates decrease bone resorption, thereby slowing bone loss. Bisphosphonates are widely prescribed for osteoporosis. When you look at the HEDIS scores, the Health Examination Data Information Set, it's a standardized quality data set. It's used by many HMOs, it's used by Medicare. For our new Medicare Advantage programs, HEDIS will be following us to make sure that we're doing things that show improved quality. One of the things they'll look at is use of bisphosphonates for osteoporosis fractures. Bisphosphonates are incorporated into newly formed bone and can persist there for years, so they decrease that bone resorption. Patients are exposed to pharmacological effects long after they stop taking the medication, and we'll actually talk about that in just a minute too. Recently, data on safety have raised concerns about the optimal duration of use for achieving and maintaining protection against fractures. So as you see in the image up here, resorption is greater than formation, bone turnover is high, and you start to get loss of that bony matrix. With bisphosphonates, resorption, you get decrease in resorption, and formation and resorption end up being about equal, and then the bone turnover decreases. That bone remains there. So we said we were going to talk about how long you should take those. That's really the bigger issue for most of us who have looked at this. It's less of an issue of whether or not to take them. It's really more of an issue of how long to take them. Rare adverse events have been associated with bisphosphonates. Here's what happens, what people have been afraid of, what they've hit the news about. Atypical femur fractures, thigh bone fractures. And again, all of this is about decreasing hip fractures. You can get fractures in the same bone. They're atypical. They're not the same kind. They're due to having some rigid bone and next to some softer bone. Much less probability than the hip fractures without them. Osteonecrosis of the jaw. Osteo means bone, necrosis means dead tissue. So dead tissue in the bone of the jaw. That's a very nasty side effect. It's very ugly, and it happens. Esophageal cancer also happens. The FDA performed a systematic review of long-term bisphosphonate efficacy, studies in which drugs had been administered for at least 3 years. The benefit of fracture protection from continued bisphosphonate therapy 5 years and over was inconsistent. So what they began to say is, no, it's clear that you get benefit. The benefits outweigh the risks up until about 5 years. So the data suggests that bisphosphonates may be safely discontinued without compromising the therapeutic gains. The more meaningful endpoint for osteoporosis therapies is the rate of fracture. To optimize the efficacy in reducing fracture risk, decisions to continue treatment must be based on individual assessments of risks and health. Why wait for a disease and hope for a cure? I used to be an ER doc. My name is Ford Brewer. I quit ER after a few years because it was just so frustrating. Most of the things bringing people into the ER are things that should have been prevented, including heart attack, stroke, number one cause of death, number one cause of permanent disability. People think that you're just going to have those and that they're not predictable. Both of those are wrong. They are predictable, and you don't have to have them. Usually it's lifestyle. Lifestyle is more important than supplements and even prescription drugs and even stents and surgery. But the current times are tough. Major financial impact with the lockdowns that most states have been going through. We've been working on a way to make this much more affordable with a subscription process, and that's exactly what we're announcing today. We've got 2 levels. One is the silver membership, where you get access to our courses a private webinar each month, and access to our supplement store and supplement recommendations and prescription. Or I would suggest even more so, the Gold membership. You can get a script for a Freestyle Libre and find out what your blood sugar metabolism's doing on a daily basis. And you can get a lab order for inflammation, OGTT, and insulin survey. You can also get a 30-minute one-on-one with me. So I'm looking forward to seeing you. Cost is no longer an excuse. So if you're interested, go to go.prevmedheartrisk.com/prevmed-subscription or call us at 859-721-1414, 859-721-1414, or email us at myhealth@prevmedheartrisk.com. Looking forward to seeing you. Thank you.